بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the second part of the talk of the degenerative diseases of the spine. And you remember we have discussed 2 items from the 7 items in the degenerative diseases of the spine. We have finished the issue of the spinal canal stenosis, and we said that there are 3 types of spinal canal stenosis: the idiopathic type, the developmental type, and the acquired type. Then we talked about disc lesions, and we said that there are 3 types of disc lesions: disc degeneration, disc bulge, and disc herniation. And we discriminated between bulge and herniation, and there is a step before herniation which is known as disc protrusion, and there are 2 steps after disc herniation or extrusion, and these are the disc migration and the disc sequestration. Then we came to the third issue, which is the bone marrow abnormalities, and we have 3 types of bone marrow abnormalities: bone marrow edema, bone marrow fatty degeneration, and bone sclerosis. And you know that MRI is one of the best ways to assess bone marrow abnormalities. Plain X-ray and CT are not able to see the bone marrow, but MRI is good for this particular issue. Usually, when the disc degenerates, it loses its water content, then it loses its height, then it develops air inside the disc substance, which is known as vacuum phenomenon. These changes may be associated with abnormalities in the bone marrow of the vertebra above and the vertebra below. These bone marrow changes may be in the form of bone marrow edema, which should be of low signal in the T1 and high signal in the T2 weighted image. And you know this is T1 because the CSF is black, and this is T2 because the CSF is bright. And the same follows the signal of fluid, because this is bone marrow edema, and you got low signal in the T1 and high signal in the T2, usually affecting the vertebral end plates above and below the affected or degenerated disc. Then here this is T1 and this is T2, and you can see that there is some abnormalities here at the L5S1 level, which became bright in the T2 weighted images, denoting stage 1 degeneration. And this is also bone marrow edema, and you see low signal in the T1 and high signal in the T2 weighted images, denoting stage 1 or type 1 bone marrow degeneration. Then fatty deposition in the or fatty conversion of the bone marrow in the vertebral end plates at the level of the affected disc will appear bright in the T1 and relatively less bright in the T2 weighted images. And this is an example of both types. Here you see low signal in the T1 and high signal in the T2, denoting type 1 bone marrow edema. Then this is high signal in the T1 and high signal in the T2, and this is fatty degenerative changes at L5S1 level. Then the third type is bone sclerosis, which will appear black in the T1 and also black in the T2 because it is almost similar to the cortical bone. Then this type of bone marrow sclerosis is easily appreciated in the plain X-ray. You see, if the disc space is narrowed, then you got bone sclerosis at the opposing vertebral end plates. And you can appreciate this also by the CT images. The reconstructed sagittal image here shows that the vertebral end plates of L3 and L4 are sclerotic, with marked degeneration of the L3-4 disc, evidenced by loss of the disc height and vacuum phenomena within the disc substance. Then if you see low signal in the T1, then you have to go to the T2. If it became bright, and this is bone marrow edema. If it persists as black, and this is bone marrow sclerosis. But if you see bright signal in the T1, don't go for the T2 weighted images because this will represent fatty degeneration. You can see bone sclerosis in the plain film. You see this is normal disc and this is the narrowed disc with a sclerotic reaction of the opposing vertebral end plates at L4-5 and L5-S1 disc levels. Then we came to the osseous pathology, and we have three items also. You have anterior osteophytes, posterior osteophytes, and osteoarthritis of the joints in the spine, particularly the facet joints and the neurocentral joints. You know that anterior osteophytes are of little significance compared to the posterior osteophytes, which are encroaching directly on the spinal canal, maybe compressing the cord or the nerve roots or the theca. Then anterior osteophytes are only important in the cervical region, particularly if they are big, like these osteophytes, which will encroach on the pharynx and may result in dysphagia or difficulties in swallowing food. Then anterior osteophytes are of little neurological significance, but the posterior osteophytes are very important because they will encroach on the spinal canal. And you see, these very big osteophytes are of little significance, but smaller osteophytes like these ones can affect the cecal sac and can also affect the spinal cord if they are in the cervical region. And this is the CT scan of the cervical spine showing posterolateral osteophytes encroaching on the spinal canal with the big osteophyte encroaching on the spinal canal as well. Then how can you predict the presence of osteophytes by MRI? Actually, whenever you see a disc like this and you say that there is disc encroaching on the spinal canal, you go to the axial images in order to know if this disc is bulge or herniation, as we have discussed before. But whenever you look to the image at the level of the disc, and you can see some water inside or some brightness inside the disc substance. But if you came to the next level and you see this very big osteophyte, which is of similar signal intensity to the rest of the vertebral body, then you know that this disc is associated with a prominent osteophyte. In the past, they call this disc hard disc because of the presence of bone in association with the disc inside the spinal canal. And if the disc is not associated with osteophytes, they used to call it as soft disc. Actually, this terminology is no longer used, but we can safely say that this disc is associated with osteophyte or associated with traction osteophyte, and we should include this in the report for the surgeon to be ready to remove the disc as well as to remove the osteophyte as well. Then we have anterior osteophytes, which are of little significance, posterior osteophytes, which are more important. Then we came to the osteoarthritis. Osteoarthritis will affect the facet joints in the lumbar spine, will affect the facet and neurocentral joints in the cervical spine. These are the main manifestations of osteoarthritis anywhere in the body: narrowing of the joint space, subchondral bone sclerosis, marginal osteophytic lipping, subchondral pseudocystic changes, and intra-articular air or gas, and loose bodies if the joint is large, like the knee or the shoulder. And this is osteoarthritis of the neurocentral joint on the left side, encroaching on the neural foramen on the left side, while the neural foramen on the right side is patent. Then we have three osseous abnormalities: anterior osteophytes, posterior osteophytes, and osteoarthritis. Then we came to the ligamentous pathology, and we have three types also. We have ligamentous hypertrophy, ligamentous calcification, and the ligamentous ossification. Of course, what's important for us concerning the ligaments is the ligament which is inside the spinal canal. And we have two ligaments inside the spinal canal, the ligamenta flava and the posterior longitudinal ligament. These ligaments may hypertrophy, may calcify, and may ossify. In hypertrophy, the ligament itself is of low signal in all pulse sequences. And if the ligament is hypertrophied, it will encroach on the spinal canal, and this can be seen in the axial images and can also be seen in the sagittal images. This is the normal ligamenta flava, and this is hypertrophied ligamentum flava. Then because of the ligament is black in MRI, calcium is also black in all MRI images, then you cannot see calcium in the ligament unless by CT. Then this is an example of ligamentous calcification by CT in the ligamenta flava bilaterally. And this is unilateral calcification of the ligamentum flavum in the cervical spine on the right side. This is the ligamentum flavum which is not calcified, and this is the calcified one. Then there is some debate about the ligamenta flava, whether we call hypertrophy or buckling of the ligamenta flava. You know that whenever the disc space is narrowed, then there is approximation between the vertebral bodies, and this will result in buckling or crumbling of the ligamentum flavum, which will be sometimes like this, protruding inside the spinal canal. And this is an extreme example of ligamenta flava hypertrophy or buckling, and you see big masses encroaching on the posterior aspect of the spinal canal. Then we came to a famous entity which is known as ossification of the posterior longitudinal ligament, or OPLL. And this ligament can hypertrophy, can calcify, but commonly it usually ossifies. And whenever the posterior longitudinal ligament is ossified, and you got sheets of bone along the posterior aspect of the vertebral bodies. One of the very important observations is that this ligament is almost away from the back of the vertebra, except in a certain point where it is attached to the vertebral body. Then, if you look carefully here, and this is ossification of the posterior longitudinal ligament, it will appear like this in the axial image. And this is quite different from the osteophyte. The osteophyte has a broad base and a narrow apex, but the ossified posterior longitudinal ligament has a narrow base, or let us say pedicle, with a broad apex. Both can exist in the same patient, and you can see osteophytes as well as ossification of the posterior longitudinal ligament. Sometimes you got ossification of the anterior longitudinal ligament, which is of little neurological significance. Then here an example by CT, you got calcification, which is usually interrupted, calcification of the posterior longitudinal ligament, and this is the axial image where you can see the ossification of the ligament. On MRI, you got low signal in the T1, sheets of low signal in the T1, and also low signal in the T2, encroaching on the spinal canal and compressing the cord. And this is the appearance of ossified posterior longitudinal ligament by MRI axial T2 weighted image. This is also ossification of the posterior longitudinal ligament, and you can see a sheet of low signal structure running along the posterior aspect of the vertebral bodies 2, 3, and 4. Then ossification of the anterior longitudinal ligament, or OALL, as I have said, is of little neurological significance, and this can be seen usually in cases of diffuse idiopathic skeletal hyperostosis or DISH with a particular reference in the cervical spine. This is known as frost tear disease. Then we came to the spinal instability, and we have three types of vertebral displacement in relation to the the vertebra below. Then we have anterior displacement and posterior displacement. Anterior displacement is two types depending on the intactness of the bars interarticularis. If the bars is broken, then you got lytic spondylolysis. If the bars is not broken but the facet joints are the seat of osteoarthritis, then you got degenerative spondylolysis. And we have one type of retrolysis, which means displacement of the vertebra backward. And you should remember very carefully that the vertebra which moves is the vertebra above. Then, if you came to this level, L5S1, if there is any motion at L5S1, it is L5 which moves. Don't say that S1 is coming backward in relation to the L5, and this is wrong. Then the vertebra above will be displaced anteriorly or posteriorly. Anteriorly is known as spondylolysis or anterolysis. Posteriorly, it is known as retrolysis. The motion of the vertebra in relation to the vertebra below is divided into 4 degrees. From the 0 point to 1/4 of the vertebra below, and this is first degree spondylolysis. From the quarter to the half of the vertebra, and this is second degree. From the half of the vertebra to 3/4 of the vertebra below, and this is third degree. And if the vertebra above is almost totally anterior to the vertebra below, then you are dealing with the 4th degree of spondylolysis. What is the pars interarticularis? I explained this in the lecture of the anatomy. In the oblique view, and you can see the Scotch dog. The pars interarticularis represents the neck of this dog. The ear is the superior articular facet. The eye is the pedicle. The mouth is the transverse process, and the anterior limb is the articular facet of the vertebra above. Then the neck of the Scotch dog is the pars interarticularis. If the pars is broken bilaterally, then there is a chance of this vertebra to move on the vertebra below. And this arrow points to a broken pars at the level inferior to this one. And here you can see this is the region of an intact pars, and this is the region of a broken pars. And this is the configuration of the Scotch dog. Then you can assess the pars break in the lateral view. You don't need the oblique views, and you can see this is the region of the pars interarticularis which is broken, and the vertebra has moved more than quarter of the vertebra below, and this is what we call the second degree spondylolysis. And this is a severe degree of spondylolysis approaching stage 4. Then in the reconstructed CT images, in the sagittal view, you go to the sections of the midline, looking for the region of the pars interarticularis, and here you can see the pars is broken, but here is intact, and also here you can see that the pars is broken, and here the pars is intact. Then, if you are dealing with a first degree spondylolysis, then you have to discriminate between degenerative and the lytic. And you should look for whether the pars is broken or the facets are the seat of osteoarthritis. One of the simplest ways to decide this is just to look to the facet joints. If the facet joints are the seat of osteoarthritis, then This is the cause, and this is first degree degenerative spondylolysis. But if the vertebra has moved anteriorly relative to the vertebrae below, and you look to the facet joints and they are okay, you are sure now that the bars is broken. This rule applies only for the first degree spondylolysis. Starting from the second degree and the third and the fourth, the bars should be broken in all these types. It is only the first degree where you should discriminate between the broken bars or the degenerative osteoarthritis. And here, if you see the first degree spondylolysis of L4 over L5, and you look to, this is the region of the bars which is intact, and the facet joints are of course the seat of advanced osteoarthritic changes. Then one of the important issues is what's known as the pseudo disc bulge. Whenever the vertebra above moves anteriorly relative to the vertebra below, the posterior edge of the vertebra above will indent the intervertebral disc, and this will result in abnormal bulge of the disc posterior to the vertebral body. Then if you have a section like this, and you will got this appearance, you see the vertebral body with a big soft tissue shadow which is not conforming with the margin of the disc, and this shadow is encroaching on the neural foramina. This is known as pseudo disc bulge, and this is quite different from the true disc bulge, which is confined to the margins of the disc and is seen at the level of the disc, not at the level of the vertebral body. Then whenever there is retrolysis, and you see it, this is L5 is moving backward relative to S1. There is no degree. This is only retrolysis. There, you should not look for if the bars is intact or not, if there is osteoarthritis or not, and just you say that there is retrolysis of L4 relative to L5, and here in this example you say retrolysis of L5 relative to S1. Then finally we came to the cord pathology. And cord pathology, we have three issues also: cord edema, early myelomalacia, and late myelomalacia. All these lesions will appear of low signal in the T1 and bright signal in the T2. And you cannot by MRI discriminate between these three items. In spite of many things that have been mentioned in the literature, but you should know first the difference between cord pathology related to degenerative diseases of the spine and the cord pathology which is not related to degenerative diseases of the spine. This cord pathology, there is a cause for the pathology to be here, and you see that there is a disc and there is a ligamentum flavum compressing the cord, resulting in an area of abnormal signal within the cord substance. But here the cord is not touched by any lesion, as you can see, and this is in the differential diagnosis of intramedullary lesions. We'll discuss this after that, but we are concerned now with this shadow, which is the result of disc lesion as well as ligamentum flavum hypertrophy compressing the cord, resulting in this abnormal intramedullary signal. Then how can you discriminate the three? Because edema is a reversible change in the substance of the cord. Also, early myelomalacia is a reversible change. If you release the compression, this shadow will regress. But late myelomalacia will never regress, because this is permanent damage of the substance of the cord. Actually, we depend mainly on the clinical picture of the patient, and the clinician may be able sometimes to know whether this lesion represents edema or early myelomalacia or late myelomalacia. According to the literature, they said that if you inject an area of myelomalacia by contrast media, Then if it shows marginal enhancement, you can say that this is early myelomalacia. If no enhancement, you can say that this is late. Then in the MRI, we just only say that there is a big disc, and in this axial image we know that this disc is a herniation because it's focal and to the right side, encroaching on the foramen, compressing the cord. Then we say that there is a C6-7 disc, right posterolateral disc herniation with significant cord compression at that level. How did we know that this is significant? Because there is a change in the cord parenchymal signal at this level, meaning that there is one of the three previously mentioned lesions. Then here you see a disc at C4-5 and the ligamentum flavum, and consequently there is an abnormal area or area of abnormal signal within the cord substance. And this is also a C5-6 or C5-6 disc lesion with a focal area of bright signal within the substance of the cord. Then finally, you remember we have to comment on the paravertebral shadows. And in the degenerative diseases of the spine, paravertebral shadows are usually normal. But in cases of trauma, you will see some hemorrhage around the vertebra. In cases of infection, you may see abscesses in the psoas muscle, for example. In cases of tumors, you can appreciate that some of the tumors may extend outside the vertebral body into the paravertebral muscles. هذا وبالله التوفيق والحمد لله رب العالمين والسلام عليكم ورحمة الله.